Hello and welcome to episode 6 of Straight from the Hip podcast. This is Binoy and Callum, your host. So this is a really important episode, which we are slowly going into the rehab side of things because we've been setting the scene with the morphology, the presentation, the gender difference. But end of the day, as therapists, the most important thing is how can I get them better? That's why they're here. So one of the main elements which we want to address is the load management with FAI syndrome. In my opinion, possibly the most, not possibly, is definitely the number one treatment where without that, the rehab, in my opinion, doesn't really work. So what have you got for listeners today, Callum?
Yeah, we've broken it up into sections. And with Benoit, so we've started us off on thinking about everyday activities that people with FAI might find quite uncomfortable, and then we'll progress it into walking, running, gym work, and then we've also done cycling because you see a lot of spinners. I understand.
Yeah, spinning as well.
People that go to spin classes.
Yeah,
not as much of a thing here in Perth, so I don't see quite as much of that. But we've
because when you got like lovely outdoor, you don't need to be indoors cycling, isn't it? On a Zwift bike when you got a rainy day. So I think it's definitely here. So I think so.
That wasn't meant to be a dig. Sorry.
Yeah. I think this is where I think I had a big thing is when physios, when you get patients, we feel like we have to do something straight away, like some hands-on treatment or rehab. But for me, the first treatment session is all about educating because we know the definition of FAI syndrome is a motion-related disorder. So if you don't really stop that provocative load, so you let's say, Callum, you got a patient here, young active female, they're in pain, frustrated, and wondering. They're a gym goer, whether they'll be able to squat or sit comfortably or train hard again. So the first thing I feel is we have to manage irritability, and then we'll have to break down exactly how to modify the load and lifestyle so that our patients can keep moving, they can keep training and get their hips back. So those is sort of setting the scene. So what are some of the core principles which we can think about and looking into everyday modification? So you got the patient here really upset and frustrated. So how would you manage the patient and explain the importance of the lifestyle and the load modification?
Yep. I think the first one I'd like to touch on is sitting. So I think since COVID, a lot of people are now working from home and they're spending a lot of time working sat at a computer. So sitting can be problematic for people with FAI. And it is because of that deep hip flexion position. We know that's going to narrow the anterior joint space of the hip and it's going to cause some symptoms. In desk chairs, particularly with my last job in the UK, but in the FCP clinic, we had these chairs where it had an increased lordotic area to the back support.
Cool.
And a lot of people are buying those because they were told as being ergonomically very friendly. And we had people even in the GP practice using them, but they weren't the most comfortable at all. And so I would have people with FAI come in and say they've got these chairs, but it was causing a lot more discomfort in their hip. And I put down to the fact that if the chair is forcing them into that position, it could be because it's pushing their pelvis into a bit more of a posterior tilt type position. And even subtleties like that, it's not that a posterior pelvic tilt is a problem, because it isn't. But for someone with symptomatic FAI, that can aggravate their symptoms further. And it's just sitting in that period for a long period of time. So ways to modify it, I always tell people, can they raise their seat height slightly? Even if it's only by 10 centimeters, it doesn't have to be anything massive. But my visual explanation is, can they sit with their hips sitting slightly higher than their knees? So they don't actually have to measure something. If they use books and then put a cushion on top of it, if they've got some firm towels, or you can actually get these cushions now, can't you, Benoit? You can get these.
Like a wedge. I'm a big believer of wedge cushions because even you see Alison Grimaldi, she uses that. So definitely a few modifications there, wedge pillow. So I like the point, which is exactly what I use is the hips has to be higher than the knees. Yeah. Sort of offloaded. But what about other things like breaks or cross leg and other aspects of sitting? Is there something you also touch on?
Yes. Sitting cross-legged, not for everyone, but I would that can be, again, if you think about a FADIR test, if you've tested someone positive with a FADIR, sitting cross-legged is essentially like a FADIR type position, isn't it? So it would be, you can sit like that, but make sure you switch your legs regularly or try to avoid sitting like that entirely. I tend to shoot for every kind of 45 minutes if they can have a break from sitting. And a little thing that I ask people to do, because you get a 2-in-1 here, I say if you can have a sort of a pint of water next to your desk and you're drinking throughout the day. Yes. And it might be a case that we need to get in 3 pints of water a day. That's going to force them to go to the toilet. So they're going to have to get up probably every hour to go to the toilet. Yeah. So they're getting that break from sitting, but they're also hydrating their body. And that seems to be quite a nice way to get people to move a little bit more throughout the day.
Yeah.
The only other thing I give them is to try and assist in reducing some of that posterior tilt in some of these ergonomic type chairs, is if they could put that same wedge cushion or something behind their lower back to better support their lower back, that can also be helpful as well. That'd
Yeah.
probably be my
And
top four.
yeah. And I think it's most one of the things I also use is ask patients to put it on the phone, like their apps and reminders, give a ping, or the free website called Egg Timer. So there's a lot of reminders now, so we can use something to remind them. But I like your idea of the drinking water because it's going to be definitely a win-win situation. You're hydrating, and that will force you to get up as well. But if you have the wrong position and not a supportive chair, then obviously that's the crucial one. So just to key points, the height is important. The hips always higher than the knees. Breaks every 30 to 45 minutes, making sure that you're avoiding cross leg. Even if you do that, again, changing a position. So I would say that is the number one area I tend to start, which is sitting, because, whether we like it or not, modern lifestyle, Western lifestyle, we spend a lot of time in sitting and we keep on aggravating. So the rehab in the gym might be what, 40 minutes, 1 hour? Is how you spend the rest of the day, which is really important, which really builds it up.
Yeah.
So sometimes people forget, oh, I'm doing the gym exercise, I'm doing the rehab, but they forget that 20, 22 hours, what they're spending, how they're sleeping and how they're sitting. Those things are hugely important. So that goes next to things like basic stuff like walking, stairs, and things like that. Would you give any reminders or tips there for our patients?
Yeah. Probably my top few things would be, if someone's going out walking, can they try and reduce or shorten their stride length? Because if we're thinking, this probably is a little bit more applicable to women with a pincer type morphology. And we said in our last podcast, they might have a little bit of instability in amongst that. So if we increase their hip extension range of movement when they're walking, that can be quite provocative. So just getting them to increase their cadence is point two, and shortening their stride length can reduce peak hip flexion, and it can also reduce peak hip extension moments. So that can be beneficial for both men and women. Over here, more so, I'm having this conversation, Benoit. I don't know if you do this. I don't remember having this conversation much in the UK, but terrain is really important. So obviously
Okay,
here in
yeah.
Perth, we get a lot of people going out for walks on the beach first thing in the morning. So they've got their dog,
Okay.
they're out at 6 a.m., 7 a.m., they're walking on the beach. And that can actually provoke their hip. I'd probably say I see that more so in women when there's question marks about instability and they don't have that lumbopelvic or same level of lumbopelvic control as men. So I'm probably having that conversation more so with them. And I'm just saying to them, look, instead of walking on the beach, can we walk on the road or the path? Because all of these beaches have got sidewalks. Can they just be walking on the sidewalk next to the beach on a flatter terrain, even terrain,
A bit more
rather than
firmer.
uneven terrain? Yeah, I wasn't having those conversations much in the UK unless it was a case that it was
Yeah, unless you're working
walking
in
on
Devon or
grass or
Cornwall.
yeah,
You're
yeah,
not going to. Yeah, so you're not going to do that. But most people will not be walking on the sea. But the one I use in the UK a lot is to avoid the power walking and also hill walking. So I find
yes,
that can be provocating as well. So I think it's building up the volume first before the intensity. So making sure that
100%.
they're not overstriding and not going uphill, especially if you're living in that, because that puts more strain on your hip muscles. And that's true even for running. So one of the things I'll say, if anyone with the hip pathology, is to stop that hills and speed work. So the same can apply for walking as well. And how about things like stairs and transfers between cars and sleeping and other aspects? Anything you would give pointers there?
Yeah, I mean, you can understand it when getting in and out the cars and going upstairs, because naturally you're with going upstairs, you're forcing the hip into more flexion, obviously, because you need to climb the stairs. When you're getting out of the car, this is probably more applicable if there's labral pathology, but what most of us do is we'll take our leg out, we will abduct, externally rotate, we plant our foot on the ground, and then we're almost doing kind of like a shear type effect on our hip, aren't we? Because we're
Yes.
pivoting with an axial load as then we go to stand. So if someone's got a labral pathology, that can be quite provocative. So when it comes to ascending hills and stairs, I say to people, if they lean forward slightly, so leaning their trunk forward, that
Yes.
can, one, help to build momentum in just helping them to climb the stairs, but it also creates a bit of a hip hinge as well. So we're trying to utilize those extensors a little bit more so to help offload the hip flexors a little bit, so it can help to propel you forwards, bring in other muscle groups into the mix. Otherwise, use the handrail. If it is really that bad, which again, I probably see this more with labral pathologies, just use the handrail if you really need to when you're going upstairs. Try
Yes.
to slow the tempo down.
Not to run
See,
up and down. Yeah. Yeah. That's
yeah, I see
important.
people try to speed it up a little bit, because I don't know if the
Yes.
mentality is this is painful. So if I could get it done quickly, then it's done and out the way. But naturally, if we do things quicker or with more intensity, it does increase hip joint stress. So if we could try and slow it down a little bit, then that would be good. And you mentioned it a second ago, but trying to ease up the volume as much as we can. So if you're someone that goes out walking or running, try to stick on the flat, and as best as is feasible, try to avoid the hills where possible. And if you don't need to be going up the stairs 50 times a day, don't go up the stairs 50 times a day. Only go up when you absolutely need to.
Yes,
When it
definitely.
comes to the car, I'd love to hear your points on this, but I know if you've got something different. But I tend to ask people to bring both of their legs round together. So don't take one leg out first into a Fabry type pose. Just bring both legs round together. So that way you're avoiding pivoting on a fixed foot or on a single leg to almost do a partial kind of single leg squat getting out of a car. If you just bring both feet round, plant them down, and then you're using both legs to kind of sit to stand out of the car.
Yeah.
That's what I tend to do when it comes to a
Yeah,
car
so
situation.
yeah. So I think with cars, one more point is sometimes when you have like fancy sports car and you like the cockpit, like where you're really low in. So one of the things I say to them is people like non-UK listeners, there's like the shops like Halfords where you can, it's like a car shop where you can get like special addition. You don't have to change the car, but you can get like a special attachment where you can raise up the seat. So I find that makes a huge difference. So you can get this booster side of thing where you can put underneath the seat, which makes it a little bit more upright. So if you're spending a lot of time driving around and you're very low seats, I find that can also irritate. So that's something to look at, what sort of sitting they have. Definitely, I think bringing both the legs together, avoiding, the main thing is, as you pointed out, is to avoid pivoting on a fixed foot, because that gives that shearing and that sharp pain, which can really trigger that labral irritation. So is keeping your feet together and also avoiding that shifting there. I think the final point here would be about sleep. So that's the common question people ask me. Is there a particular method, particular position, using pillows? What would your advice be there, Callum?
Yeah, but before I touch on that, do you go to Halfords a lot, Benoit? Is that what you said?
Yes, I love. I'm not
Just for
this.
listeners, just
Yeah,
for the
just for
listeners,
listeners.
Benoit is
Yeah,
talking from personal experience because he drives a
yeah,
Lambo, so he has to.
yeah.
This is how he
It's
gets
sorry.
out of his car.
It's a Bugatti, man. It's a Bugatti. You forgot it. It's so yeah. So just to let our listeners know that this episode is not sponsored by Halfords, but we're waiting for. But we'll be interested in future responses. If they're interested. But yeah, but the main thing is, because it's really important. Like if you're spending a lot of time driving, so I think like conditions like hip impingement, proximal hamstring tendinopathy, those sort of conditions where the sitting is a key trigger, you can't not explore these things. How are they
Yeah.
spending their whole time? What are they doing? If you're driving 6 hours, they're sort of more like a sales job where they have to travel around. You must know what car they have and what's the setup like, and you can make some simple modification, and that's all you need to have a big effect on their. Because they don't have any choice on, if the job means driving 6 hours, they have to do it. But can we make it a bit more comfortable? Can they take the breaks? And they sort of, obviously, let's not get involved into the food you get on the stores, where we stop on the motorway. The food is rubbish anyway, but but at least you can have a break. And people understand that it's a load based element there. But so yeah, regards to sleep here, one of the things I say is keep the pillow between the knees, sideline, possibly avoid full fetal curl. And so it's very positional. I don't think there's any perfect position for hip impingement. Anything you would say here?
Yeah.
Unlike
I think the only conversation we can have regarding sleeping is how can we help you set yourself up so that you can get to sleep okay. Obviously, that we all move about when we're sleeping. We can't control that, but if we can put you into a setup that can at least help you get to sleep, which
Yes.
I agree, avoid fetal curling up. It's a deep flexion, whether it's a pillow between the knees. I have tried asking people what happens if you put the symptomatic leg in a bit more of an extension bias, not full extension.
Yeah.
But if you just take the foot back behind your body a little bit more, does that help? And it's a bit of trial and error when it comes to sleeping.
Yes.
There's no hard and fast rule here. But as long as you can understand the mechanism that causes this impingement type symptoms, how can you keep someone out of it when they're going to sleep?
Yeah. So the next big element which we need to address is, most of the patients I see with hip impingement are gym goers. So they're generally very keen, either gym goers or running or doing cycling. So training is a big part of their life. And one of the frustration they come to us is they can't train at the level or intensity or the depth they want. One of the biggest mistakes I see, especially when somebody is not used to treating this patient, is stopping them totally going to the gym. That's not, I have to make it very clear, that's not an option in this group. They will find somebody else. They want to go to the gym and we have to keep them in the gym. Very rarely, unless they are in a very bad flare up where they're limping, night pain, I might just give a break for a week or something. But nearly all my patients, I will keep them in the gym because that's where it's a big part of the identity. So how can we keep them in the gym, and what are some of the modifications which we can make them to avoid irritating it, but also training them without causing further problems? So over to you,
Yeah.
Callum.
Yep, I couldn't agree with all those points you said. They're benign enough, to be honest. Agree with every point you said. I'll go through some of the typical stuff that I would see. Yeah, I'm a gym goer, so I get where these patients are coming from if they feel they can't lift. So if we go into a squat, which we know is a particular provocative maneuver for someone with FAI, we want to keep them squatting as best as we can. But as we know, it's that deep flexion, it's that axial loading, which increases that compression. So the ways that various ways, you can give these a try. You can start off by limiting the range of movement. I think that's the first thing that I do. Probably 9 times, if not 10 times out of 10, can we limit the depth initially? So do we get them to just do a box squat? Or do we set up safety frames if someone's a very avid gym goer? Do we set up the safety frames in the squat rack so that they're just squatting down to where the bar hits the safety frames and then they come back up? Or are you placing a box behind their bum for them to not sit on, but to just touch to before coming back up? That's the first thing that I'll do. This probably is a bit more applicable to blokes, a wider stance, and I'll get them to evert their feet a little bit more. I think with all of the trends that go on TikTok, Instagram, YouTube on the correct ways that you should squat, this is the other big educational part that I say to people. There is no correct, optimal way to squat. We just have to get someone squatting in a way that feels comfortable for them and feels natural for them. So I said, this is a bit more applicable to blokes, having a wider stance. If they can externally rotate their hips by placing their feet into a bit more eversion, that can be less provocative on their hip. Can they control the tempo? So sometimes I get people to reduce the amount of weight that they're lifting. And I'll say, can we increase the eccentric phase of your lift? So can you be squatting down for 5 seconds, 6 seconds before then ascending? So that way they're still hitting intensity with their back squats, but we've reduced the load and we've possibly reduced how low they're going into flexion. So they're still getting that kick out of their training. And the final thing is I'll reduce either volume or frequency. So I meet some gym goers that will be training legs 3 times a week.
Yes.
And in each of those leg sessions, they're doing squats. So that's a frequency issue. So I might say to them, look, we don't need to be back squatting on 3 different days a week. So maybe we adjust that. Other people, they're training legs twice a week, but they're doing back squats, they're doing deadlifts, they're doing leg press. They're doing too much squat pressy type movements, too much volume within one session. So sometimes we'll make an adjustment there. They're probably my top 4 when it comes to squats. Would you have any different ones?
I think, so I think it's giving variation. So I like that variation of giving them box rather than saying don't squat. I would say these are some better options where you can still squat. So box squat, I prefer more front loading, and many gyms might be similar. In Australia, they tend to have the safety bar. So where you keep that in the front, so more upright position, maybe also the goblet type where you can really use as priming that movement there. So the depth, so if you want to simplify it rather than overloading them, there's 2 points I always focus: the depth, so the range, and number 2 is the foot external rotation. So keeping around like 30, 40 degrees, which is the natural fit. That generally will clean up most patients' symptoms. So giving them variety, and you're totally right. Some people squat every time they go to the gym, and you don't need that at least 3, 4 times. So the volume, and that is really important. How about other leg exercises like the deadlifts, the lunges, the leg press? Those are something also can be advocating. How would you modify those?
So we know the movement pattern is very similar. So if we take a deadlift, and I'm talking a conventional deadlift here, not an RDL. So 3 strategies that I tend to go for. The first one is, can we elevate the bar so that it's sitting higher from the ground? So you can either use blocks. Some gyms have weightlifting blocks. Mine doesn't. So we just use plates. So whether you stack up a 20 kilo plate or 2 15s, whatever, and you put your weights on top of those plates, you've effectively elevated the floor. So they're not actually lifting the bar from as low a position. So they're not in as much trunk lean, they're not in as much hip flexion. So that way they can still deadlift. Probably lift even heavier, possibly, because they're not going through as big a range of movement. So again, we're feeding into that intensity and their identity, as you said a minute ago, Benoit. I personally love the trap bar.
Yes, I love it.
So I'm a bit biased to this. My straight bar Olympic deadlift technique is average, but my trap bar is pretty good. Again, it's a fantastic setup if you don't want to find a way to raise the floor up. You're not deadlifting or squatting from as deep a hip flexion position using a trap bar as you are a conventional bar. So again, instantly, that's another fantastic variation and to change things up. If someone's really struggling, I'll also prioritize a hip hinge pattern and less of a knee hinge pattern. It depends how provocative their hip is. This is probably the one that I use the least. Those first two I mentioned, the probably two I use more. This is for someone that's got a bit more of a provocative hip and they're just really struggling. If I've failed with those top 2 points that I've mentioned, I will then start to cue a bit more of a hip hinge pattern when they are doing their conventional deadlift to bring in a bit more glute work as well. Have you got any other suggestions? You try?
So definitely my go-to is always the trap bar, because I think most gyms in the UK tend to have it. It's a bit more
Yeah.
safer loading from the side, and you can even go heavier. Whereas you need good form and technique when you do your traditional barbell front loading, the deadlift. So, and especially when you're in pain, that's something which could be a problem. And also the hinge pattern with the Romanian deadlift, or you could start from a machine, Smith machine. So it's reducing that deep range and not really taking it from the floor. The whole point is reducing that hip flexion and going
Yep.
for more like hip impingement. One of the main other provocating one is the leg press. So what would you say? Obviously, it's similar to the squat pattern. What would you say? Some modification, because obviously there are two types of leg press you see in the gym. One is the horizontal one is the vertical one. My preference is always go for the horizontal one, where you're not really having that gravity back in, but the foot position. So any tips there, Callum, on leg press?
Yeah, again, I personally am not a fan of the 90-degree angle one. So for anyone that doesn't know, so when you're up, your upper body is upright sitting as if you were in a chair. And then your legs are pressing literally parallel to the ground. Again, I have my biases, but I tend to prefer people to go for more of that 45 degree angle one, where you're pushing a little bit more in an upward trajectory rather than a horizontal one. So if someone is pressing horizontally, I will try and encourage them more to a more vertical type press. In either scenario, I would, again, stop that hip flexion range of movement. So don't let the knees necessarily come to the chest. And I do get this more regularly, people then say, but I want to work through as full a range of movement as I've got available to me. I don't want to stop that range of movement. In which case, I would say, okay, can we have your foot position wider, a bit like the squat, externally rotate the feet and the hips, even have your foot placement maybe slightly higher up the pad, because you're going to bring a lot more glutes in that way, and then almost let your knees go past your chest. This is more for blokes.
Yes,
I wouldn't
definitely
say I use this very much for women, but more for blokes, where we know they've got retroverted hips, pelvises. We spoke about that in the last episode. They like being in a more abducted, external rotated position, typically. So let's feed into the leg press, and that might make it a lot more comfortable. And again, control the eccentric phase of the lift. I would really get them to slow it down. I don't want them to feel that they're bouncing in and out of any lift, regardless of machine or compound lift. So if they can slow down that eccentric phase, we keep the intensity there. We might have to lighten up the load, but then again, we're feeding into that training mindset of, I want to get a good workout. I want to sweat. I want to feel those DOMs in the morning.
Yeah, definitely.
That'd be my top three with the legs.
Yeah, definitely. And the last one on the leg machines, on the leg workout, is the lunges. So there's obviously various types: walking lunges, split lunges, forward lunges, reverse lunges. So many options there. And sometimes I do get patients who say the lunges makes it worse, especially when they go to aggressivity on a Bulgarian split squat or something like that. They go so deep. So any tips on the things to avoid initially, or the range? What would be your go-to lunge variation for patients in this early stage?
Yeah. I don't know about you, Benoit. Most people don't like lunges. So if I say, let's remove it, they're quite happy doing that.
They're not going to complain. Yeah. It's hard work, especially the walking lunges is hard work, So, but it's one of the best exercise. Like one of the exercises which is not used, in my opinion, is like the sledge push and the walking lunges, which is my go-to at a later stage, because nothing conditions your legs better than that. But let's start with somebody who's a bit more irritable.
Yeah.
Would you totally stop it, or would you make some modification or some variations?
I'm always modify before remove. Unless that person really wants to get rid of something, then we'll do it. But you mentioned it. I'd be going for a reverse lunge. So if all they do is forward lunges, let's go reverse, because reverse lunges is much less provocative on that anterior capsule of the hip joint. So that will instantly help you. Whether they're traveling backwards or whether they're just doing alternating one step back and alternating their legs, I would go reverse rather than forward. I tend to encourage people to shorten their stride length, a bit like we spoke about walking.
Yes.
Try to shorten your step range, because that will push your hip into greater extension. This is on the reverse leg, also on the trading leg. You're going to push your front leg into deeper levels of hip flexion as well. So if we can just shorten that, we kind of get 2 in 1. We're reducing hip flexion and extension range of movement, or levers in both scenarios. I also give people zigzag lunges as well. which is something that
Can you explain for the
people
listeners
won't do.
what do you mean by zigzag? Yeah. How
Yeah,
does it
so
look like?
zigzag, wish I could show you on this podcast.
Yeah.
No, you're just stepping out to the side a bit more. So if you think that most of us are trying to lunge along a tightrope, sort of
Like a
almost
straight
along a
line. Yeah.
line, yeah, so whichever leg you're placing down, you're trying to place it down on that tightrope. My cue is we want to avoid the tightrope. So if you can make sure that you're placing your foot down on the other side of that tightrope, you're moving in much more of a zigzag type pattern rather than in a straight line.
Oh,
Again,
brilliant.
probably more so for guys. I wouldn't say I do this much with women. I tend to go for the shorter stride for women, but for guys, it pushes their hip into a bit more abduction, a bit more external rotation. It's a little bit nicer on their hip
Yeah.
joint. So a zigzag lunge can be a good one.
I can see the benefit of that to reduce the excessive hip adduction and internal rotation, which is a provocative factor.
Yeah.
Because when you're too close, that's always a concern. So usually the main reasons I find it's provocative is that excessive extension in the initial stages, which is provocative because the capsule
Yeah.
is not ready for that, and the excessive adduction and internal rotation, which can happen in the narrow stand. So definitely, I'm going to try the zigzag lunge in the gym next time because I feel the more variations you give, it's going to be better for patients. So the reverse lunge,
Yeah.
the split squats. So those are the key ones. So final point here before we go on the cycling and other things is the core work. So a lot of my patients will be doing like high knee raises, up crunches, flexion drills, Pavlov press. So core element is an important element. So do you think, is there something we need to be mindful of or some modification, especially for patients with an irritable hip?
Yeah, the one that I see a lot of here in Perth is people are doing a lot of hanging leg raises or hanging knee raises.
Yes.
It seems to be quite popular. We've got something called Fit Stop here. Think
Okay.
of it as a bit like maybe an F45 type thing that you would get in the UK, but it's high intensity training, and they seem to do a lot of hanging leg raises or knee lifts and that. And because you're chucking the hips into big ranges of flexion done at high speed or at higher velocity, and you're doing it repeatedly, that's problematic. So I tend to ask people to go down more the route of anti-rotational work. So it could be something like a Pallof press, or if you're in the gym and you're using cables, you can be doing cable type wood chops, something like that. You can be doing either prone. So I get people do mountain climbers. So when people are in a plank position and then they're alternating, they're bringing their knees up to their shoulders. We might just remove that and we'll get them into a prone plank, or we'll get them into a side plank, or we just control the flexion range. So we can still do the mountain climbers. I'll just say, just don't bring your knees quite so high up. Same with things like dead bugs. Great exercise. As long as we control the hip flexion range, we don't have to remove it entirely. Let's just not take the hip so far into hip flexion.
Yes. And one of the things I make quite strict at is the twisting, like the Russian twists. So when you have that sort of adduction and twisting, that can be too much in the initial stages. But again, it's just going back to the pathology, which is flexion and internal rotation. So the deep-seated twist, the Russian twist, especially with the medicine ball, they're great for the core. But again, something which we might have to modify in the initial. But things like modified dead bugs, the Pavlov press, cables, using the cable chops. Because yes, I definitely don't see a lot of hanging knee raises. So I can see how that can be provocative in this patients initially.
Yeah.
So the last element is a big one. We see a lot of indoor and outdoor cyclists, whether it's a spinning class or they're going outdoors. So cycling, I do see quite a bit of patients who come to me with hip impingement or a long distance cyclist. And I think we can't forget the bike setup here. That's a huge topic, and that's not definitely my area of expertise. So we're not going to go into the bike setup here. But what are some simple, because we don't want to create this message that cycling is bad for the hips, which is not the case, but it can be provocative, especially repeated flexion. So what are some tips you would say for somebody who's spending a lot of time on the bike or a spinning class?
Yeah. Yep, and look, I would say that in terms of cycling, I would put myself as less qualified than you, Benoit, because I don't see many cyclists. Spin classes do happen here. I don't think they're as popular where I'm based. So this advice is more based off of my understanding of obviously the hip impingement and what the bike setup could probably do for the hip, good or bad. So again, we'll go back to sitting. Can we raise the seat height a little bit further? Again, it might just be as small as 5 millimeters, it might be 10 millimeters, but if you can raise the saddle height, that can create a little bit more of an open hip space, if you like, when you're going through that stroke action when you're cycling. The handlebar position, I think, is a big one. So if the handlebar is too low, it's going to force you into more trunk flexion because you've got to lean forward that bit more to get your hands onto the handlebars, and it is going to push your hip into greater range of flexion. So my basic advice is, can you just raise the handlebars a little bit more? Can you bring them closer to your body so that way you're not reaching quite as far? That will take you out of that trunk and hip flexion, combined flexion movements there. So that way you're sat in a much more upright posture when you're cycling. It might mean that you won't be able to create as much sort of momentum or speed when you're cycling. But if that's the case, we might be able to up the resistance, of the bike. So that way you're still hitting that intensity where others might be going a lot quicker than you. You will be working at a much higher sort of resistance on your bike so that you're still getting that same intensity. You're just not leaning forward quite so much and not pushing your trunk and hip into as much flexion. They're probably my
Yeah.
top ones.
Yeah, definitely. I think the low hanging fruit is definitely the height and also the handlebar. Because if you're going into that forward lean, I find that can be very provocative. So it's more the upright, what we call the Dutch style, where you're more upright, where rather than going forward lean, will make a big difference. And one of the things is also not having too much resistance.
Yeah.
You obviously can keep the cadence, but too much of resistance can be, especially long uphill climbs, can be a problematic. But this is where I think working together is really important because, as you mentioned, it's definitely not my area of expertise. For example, if it's a runner with hip impingement, I'm more than confident to see the gait analysis, the mechanics, and things like that. So somebody who's spending a lot of time on the bike, I would, at a later stage when they're going back, I would definitely refer to a colleague who can look at a proper bike fit, who has expertise. We have to work together because there's quite a few physios here in London I know who specialize in those sort of high end bike. If they're spending
Yeah.
5 to 6 grand on a bike, the bike fit is such a important element of their biomechanics. So definitely at a later stage, please do refer for an expert opinion on that subtle biomechanical changes. But most people at the irritable stage, they will benefit from this. Is that bike fit? Is it a common thing there? Do people invest in all those? Is it not a big deal in Perth? Do you see a lot of? I think in London, it's definitely a huge element.
Yeah, I've got a guy that I studied physio with. I know that a couple of years ago he did the course with bike fitting. So I know it's quite popular in the UK.
Yeah.
I haven't come across it. I've only been in Perth for 6 months.
Mm.
I haven't met an avid cyclist. I meet avid runners. There's lots of runners. I meet skateboarders. Skateboarding's a big thing here, and rollerblading's a big thing here. Swimming is huge here because people are out in the sea. A lot of water sports that I'm encountering, but cycling I haven't encountered a huge amount of. I'm sure it happens. It's not to say it doesn't, but I haven't come across many bike fitting courses, physios in my 6 months here so far.
Yeah. But again, if it's just somebody who's doing a bit of spinning and other things, this basic advice will be more than adequate to get going, because most people are not spending like 5-6 hours. They're just maybe doing a couple of classes or a Peloton bike or something like that. So so I think just to keep mindful of the time, so let's go to some of the key points. Here is the load management is critical, and we can put that nicely into these two groups. One is the ADLs and one is the gym-based modification. And when we look at everyday activity modification, the number one has to be sitting. Is raising the seat, taking breaks every 30 to 45 minutes, doing cross leg, having a good supportive chair, making sure the hips are always ideally higher than the knees. And in an irritable phase with walking is reducing the stride length and reducing that end range extension, because that can be provocative, and avoiding too much of hills or too much of stairs. And even if you're doing stairs, having slight forward lean will make a difference in engaging the hip extensors. And with cars is making sure that when you're getting out is avoid pivoting on a fixed foot, trying to bring both the legs out together. So those are some of the key elements which can have a big element. One thing which I sometimes use is if you have somebody with a lot of irritability, I sometimes will reduce their step, how many steps they take if somebody's in a lot of pain, I will ask them to possibly keep the steps less than 8,000 or something like that. So which will give an indirect idea of how much load. It's not like set in stone, but we need to be mindful. If somebody is doing 18,000, 25,000 steps with a lot of pain, that can also be a factor. And a big one has to be the gym, because most of my patients with hip impingement are regular gym goers. And the most provocative can be squats. They don't have to stop the squat, but adding variations like the box squat, a bit more wider stance, and definitely reducing the depth and controlling the tempo is crucial. And both myself and Callum's favorite with the deadlift is the trap bar. So the trap bar is a safe option to reduce that hip flexion, to load them safely, and also to prioritize the hip hinging pattern. And with the lunges, the reverse lunge is a great option because you're not going into that forward flexion. And if you want to reduce that hip adduction, you can add the zigzag lunge pattern to avoid that internal rotation and adduction as well. And with core work is avoiding that excessive hip flexion, like high hanging knee raises, the Russian twist, we prefer anti-rotation work like the Pavlov press, dead bug with control hip flexion, and plank versions with the neutral pelvis. So those are good options rather than irritating them. And final point is with the spinning. So when you talk about spinning, it's all about the height and also the handlebar, making sure that they're a bit more upright and also keeping the hip angle open at the top. So I think the key mistakes not to do is not respecting the irritability and chasing a perfect posture rather than managing load. It's not, we can't just blame the morphology alone, but ignore modifiable factors. So, and one of the things which a lot of patients miss is that cumulative sitting load. If they're sitting like 6 to 8 hours in a improperly supported chair, no breaks, very low chairs, no amount of rehab will make much of a difference because you're spending a lot of time in a provocative manner. We have to be careful here not to say sitting or cycling is bad. It's more like, I tend to use the word like it irritates the soft tissue. We are sensitizing the structures, which will mean that your pain experience will be higher. So it's not the exercise is the enemy. It's more like unprepared range and also the load, so cumulative load. So we have to be careful with the language we use because we don't want to create that sort of fear along that, because that's the point which we have not touched. So do you think we have to be careful about the language we use, that it's bad for the hips? Something which you're not. What would your thoughts on that, Callum?
Yeah, I was just thinking it as you were talking there, because I mentioned we've spoken a lot about morphology, but I also mentioned earlier in this podcast about pelvic tilt positions. And I know that there's going to be a lot of physios out there that straight away going to go, "Oh, what are you talking about? Don't talk pelvic tilt." Look, we have to just take a step back here. We're not saying that morphology is bad. We're not saying pelvic tilt is bad. We're not saying that we can influence these things directly, because we can't. And we're also not saying that morphology versus an anterior or a posterior pelvic tilt, we're not saying those are direct cause and effects to someone's pain, but they are influencers. That's all that they are. They each play an individual influence, just like lack of sleep, lack of hydration, lack of fuel, lack of all these other stuff can influence the body. So I think that language and the language that I'm using, and I've pulled that up on purpose because I don't want any physios, osteos, chiros, whoever's listening to this, to look at you and I here and think that we are sort of bad-mouthing pelvic tilt, bad-mouthing morphology, because that's not the case at all. We're just highlighting them as things that we can influence to help someone. Same with patients. We're not saying that cycling is bad. We're not saying that their hips are bad. We're just saying that these are things that might influence your pain. So if we can tap into that a little bit, it might influence things to help you feel a little bit better. So I think language is very important for patients, but also for people in our profession as well.
Yeah. I think what we're trying to do here is with this podcast is giving tips to modify, to restore tolerance. We're not trying to protect them forever, because eventually you'll have to sit, you have to squat, you have to cycle. So the hips are designed for that. But when you're in an irritable state, we're making, that's true for anything, for somebody with an Achilles tendon or GTPS or any, we always try to start with the load modification. And the hip is no different. So I think the language is really important rather than saying it's going to cause any damage or sitting is bad, because it is not. We're designed to sit, but when you're in a lot of pain, making that small changes can have a huge impact. We're not trying to chase a perfect posture here. It's more about managing loads and making those modifiable factors as well. So there you have it, guys. So practical load and lifestyle modification, which you can start using with your hip impingement patients on Monday morning. So remember, the goal is not to wrap them up in cotton wool and stop all activities. It's finding the right dosage of movement that'll keep them progressing without poking the bear. So if you find this useful, please share with your colleagues, leave us a review, and please share with your patients. I think I might start using this episode to share with my patients, because I spend a lot of time with active modification. I can send them this podcast and say, we've covered all the load modification, because that's a lot of time, really. We're talking about 40 minutes going through everything. So I can give them a handout and say, we're covered here. Those are the key things. If you've got any concerns, you can come back. So hopefully, we hope this episode can be shared with patients, because that is what I tend to do. And it's made my job.
Have you got your Halfords handout, Benoit?
And you can use the code Halford.10 for extra. Yeah, I think we should have, looking back, I should have got a sponsor for this episode, because that is, but definitely the things like wedge pillows, few things, simple modifications can make a big difference. So hope you enjoyed that. We'll see you in the next episode of Straight from the Hip. Thank you, guys.
Thank you.
Back.